Welcome to the CINP Young Psychiatrist panel. Today we're going to talk about depression, and we're going to focus specific on measurement and specific effect of SSRIs. So, Fredrik, would you like to comment on that?
Yeah, sure. I mean, it's been a sort of a well-established truth regarding serotonergic antidepressants that it takes about 2 weeks or so for them to have any effect whatsoever. And I think in the last decades or so that has been quite comprehensively challenged. I'm not sure how familiar you are with the works of Catherine Harmer, for example. Are you aware of the? Yeah. So for those who might not be, it's basically that you can see very, very rapid effects in cognitive processing in SSRIs. So you can see this both in healthy volunteers and in depressed patients. And when we say very rapid, it's like hours. And what she has demonstrated in a variety of different measures is that you subtly affect effective processing, so that, for example, ambiguous situations that you might interpret as something quite negative or something neutral or something even positive, that those situations, depressed patients, which has been known for a long time, have a negative bias in these instances. So they would tend to interpret things in an overly negative light, whereas as compared to normal persons. And then that SSRI treatment actually reverses this and makes the depressed patients behave more like non-depressed patients, and that this is a very rapid effect. And just to follow that up from a randomized clinical trial perspective, is that we have been doing a lot of analysis using like item level data on the SSRI population when they were first tested in depression, like paroxetine and sertraline and citalopram. And what we found was that you can actually see a lot of the effects of SSRIs already after 1 week. So you can see an improvement in depressed mood, an improvement in feelings of guilt, which is another HDRS item. You see an improvement in suicidal ideation and psychic anxiety. And these effects are significant, and they're present already after 1 week. They're not that pronounced, so it still takes a couple of weeks for the real big difference between drug and placebo to be established, but you see these effects already after 1 week. And the reason why you don't see them when you look at the entire HDRS scale is because there are other items which are overlapping to a great extent with SSRI side effects that are actually significantly negatively affected early on in treatment. So if you look at gastrointestinal symptoms, which might cover nausea, for example, which is very common as an SSRI side effect, that's significantly worse in the SSRI-treated patients as compared to the placebo ones. And it's the same for somatic anxiety, and it's the same for weight loss, even though that's sort of iffy since it's only 1 week. But you have very early effects of SSRIs also in the clinical trial materials, but they're in different directions, and the net effect on the HDRS scale is zero effect.
I'm glad you mentioned the suicide risk, because a lot of people ask, and companies like, can actually the depression cause suicide? So what's your view on that?
Yeah. Should someone else start? Or?
Well, I think the evidence are really controversial on that. There are evidence from multiple levels, like the randomized clinical trials. Absolutely, there's a big meta-analysis, I think 2 years ago, that summarized that in child, adolescent, and young people, there's almost like a 2-fold increased risk of suicidal ideation, although we know very little about the actual suicidal attempts or suicidal deaths from the randomized control trials because they are so rare. Whereas other evidence from ecological studies or epidemiology studies that actually look into suicidal attempts or suicidal deaths, then the evidence are really not inconsistent. There are studies showing an inverse relationship, meaning that SSRI actually protect against suicide deaths. But there are other studies also showing that SSRIs may increase the risk of suicide attempts. So I would say that actually reflects some of the challenges that we see from clinical studies to sort of real-world settings, because what we usually measure in clinical trials, suicidal ideation, it's not exactly the same as why people put in actions to harm themselves or try to kill themselves. So I think that's actually one particular challenge. And also another particular challenge that differs in randomized clinical studies and observational studies is that in randomized clinical studies where you actually do remove all the background factors or confounding factors by randomized treatment, whereas in observational studies, you just observe the patient. They could be very different in a way, those who received SSRI versus those who did not receive SSRI or receive other treatment.
Mm-hmm.
And those background factors may also influence their risk of suicide, which more complicate the questions.
Nikolina, Fredrik, any
I'd like
experience with that?
No, I would like to add actually something on the point that Fredrik made before about the very early effects that are seen. So Catherine Harman, yes, she did very, very interesting studies and showed that you do have within hours early effects on emotional processing, one aspect of cognition. And these effects actually can predict the overall antidepressant response in the long term. So at 6 weeks' time, a few of the patients that actually had some early effects on acute dose of an SSRI, they had a bigger response and the biggest change in the depressive symptoms as measured by the relevant scales. That's quite interesting because I suspect that will bring us to the next topic of cognition and how that is affected in depression and also how it is affected by SSRIs and antidepressants early on in treatment and later on.
So to sum up, recent research has suggested that serotonergic antidepressant has shown more rapid effect, but what about older age? What's your view on that? We mostly talk about adults or younger adults when we talk about the 3 to 3 weeks period of having to act. What about, because a lot of papers mention 6 to 8 weeks in that population, so what's your view on that?
Yeah, I could have a very brief comment on this actually, because we've done a lot of patient-level meta-analysis, and one of the things that we have looked at but haven't actually published anything on is specifically moderating influence of age. And if you look at the major studies in the not the very old, like the 65 to 80 age category, then it seems like the effect of SSRIs and other antidepressants is more or less the same as it is in the 18 to 65 age category. And the one thing that we noticed when we looked at this quite superficially is that they actually had a more delayed response. But this could sort of be and that was a response on depressed mood that we checked. So instead of 1 week, it took 2 to 3 weeks on average for a difference between placebo and SSRIs to establish itself. But this isn't...
the placebo one, it's very important, and I would like to discuss it in the next video.
Yeah. But it isn't exactly... That isn't a perfect analysis, because the trials in the elderly are they're different from the trials in the young adults or in the middle-aged adults, because you usually start elderly patients at lower doses and you titrate them more slowly than you do in the 18 to 65 age group. So it could also be that they don't really respond that much more slowly, but that we start at lower doses and titrate more slowly. So it's difficult to get away from that potential confounder, since that's the way the studies have been conducted.
Yeah, additional also comorbidities and other confounders
absolutely.
Make it quite hard actually for many studies to be conducted in elderly population, unfortunately.
So any other comment before we proceed to the next video?
No, I mean, we should probably mention, with regards to suicide, we should probably mention the most comprehensive analysis thus far, which is the 2009 paper by Stone. It was all studies submitted to the FDA of all antidepressants for all indications. It was about 100,000 patients. And that's probably the best evidence that we have thus far. And what you basically see is that we can't say anything about suicides, because those are too few. So there's no possible way to get any meaningful inference from so few events with regards to suicides, and that's true for all populations, because in the very young, they had a separate paper by Hamad on adolescents and children, and there were no suicides whatsoever. It was suicidal behavior, but no suicides. So we can't really say anything about a protective effect of antidepressants. What's sort of important, on the other hand, is that one of the main concerns that have been lifted is that SSRIs and other antidepressants should provoke suicide in non-suicidal patients. And that seems to be I mean, it's definitely not impossible, but if it's happening, then it should be happening with a very low event rate, because you still have 100,000 patients, majority of whom have been treated with antidepressants. So if there was a strong suicide-provoking effect, then that would have shown up, I would have imagined at least. But you can't really say anything about suicides, or at least not about a protective effect of suicides. When it comes to suicidal behavior and suicidal ideation, then you seem to have sort of an age-dependent effect. There's an interaction between treatment and age, in that you seem to have a increased risk for these behaviors and and suicidal ideation in the younger adults and in the children and adolescents. So the cutoff the FDA used was below 24. And then you have sort of a null effect in those 24 to 65, and you have a clear protective effect in those in old age. So that's, I mean, it's not perfect, the data. We would like to have more, of course, but it's probably the best, most comprehensive analysis that we have thus far.
So I think you covered very well the paper point of view. So I would like to close with a more clinical point of view. So a lot of clinicians think that the antidepressants don't actually cause suicidal risk. The suicidal thoughts are already there. So by helping them getting better, they still have the thoughts, but they actually have the power to commit the suicide. So there's a critical period that every doctor should be aware and make the family aware. And I think that's one of the most important take-home messages of this video. Thank you all for being here.